Warm good evening to all. At the outset, let me thank the organizers for giving this opportunity to spend the evening with you, afternoon with you. My pranams to T.V. Ramavariyar, our founder. Regards to Sri Krishna Kumarji, and my respects to all my gurus who has put me into this way. My dear senior doctors from the Ayurveda pharmacy branches, my teaching colleagues, students, practitioners from other institutions. Whether we had a very long session, and now only my junior Dr. Vatsala told that from morning to evening now, hearing on cervical spondylosis, now we may start developing lumbar spondylosis also. Anyway, it's a very good attempt that our institution is acclaimed as one of the center of excellences, and CME has to be a part of the program to improve our mettle. The panel discussion was quite effective. I think that is what is intended. A very good dialogue, and then I think that Dr. Ramanohar will be happy, and his team will be happy about it, that any scientific society there should be a very good debate. And the debate comes out not by nodding the head on one side only. It comes by nodding the head the other way also. And that makes the science living. And what is intended in that is also, we try to make use of one tool to introspect ourselves, how much we know and how much we have to expand. Whether any new knowledge which we will imbibe will make a sense of change in how we target the objective of giving some relief to the ailing patients. So basically, now I am not going to talk as a nosologist, but the situation, I thought that from the last panel discussion and seeing the topics distributed, I thought that something into the examination part of a patient with the complaints of cervical pain will be good enough. So the plan is that I will run through, please excuse me, there won't be any time for explaining out the different tests which may be carried out. This is from, we heard that from the manipulative medicine or chiropractic's point of view also, who have imbibed things from the modern neurology and modern little examination system. So that we will run through. My students, please excuse me, you have to, I am giving you a job also, that you can take down the signs or symptoms or tests and then go back and refer and learn also. So after that, already my job had been done easy, very easy by the considerations of the topic by Dr. Ramesh Warrior as well as my own senior colleague Dr. Sri Kumar. There won't be much difference to be in point of view, but I will rather try to explain out from the practitioner's point of view where what is to be done. So I think we will be on. I promise that I will be able to go through this session in an hour. This is actually this cervical spine clinical examination. It is a borrowed presentation only. It will take actually an hour, but I am trying to minimize it for 15 minutes because we are all qualified doctors and there is no third year student here. So let me go through cervical spine clinical examination. In this presentation, I will be using very less of or no Ayurvedic terminology, but in the strategies, surely we will be dealing from the point of Ayurvedic knowledge based or compared with the modern inputs also. Cervical spine anatomy has been already described, shown, seen. Orthopedic examination of cervical spine, I am just rushing through it, please cooperate with me, involves the taking of a history, performance of physical examination procedures, and laboratory evaluation, which may include imaging studies. That is the summary of it. The regular process, chief complaint interview. The regular process is suggested for all patients presenting with neuromusculoskeletal conditions. We start asking about the main complaints. The history should precede all physical examination procedures, but it should include the observation also. We tell that as practitioners, we know that we observe the patient when he is coming into the clinic itself, whether he has a torticollis, one word which was never used here, whether there is a listing of the head, whether there is a slight bend of the head with a rotational defect, which gives a lot of information right from the moment the patient is coming inside. Whether even the gait can be watched. There was interesting questions. Even in some lesions, the gait is also defective, and whether that is there also we can see. So generally, we should spend some time to hear the history of the patient, hear the problem. One thing regarding cervical spondylosis or most of the conditions, musculoskeletal conditions which has pain as a main is that there should be a iota of patience with us to listen to the patient. If we don't have that, and if the patient feels that he cannot share his pain with us, then I think the whole, whatever theoretical propositions we make in diagnosis and treatment and anything, it's going to be a waste. Because many of the stress relief textbooks on stress relief and all can say that neck pain, 75% it may be as described functional, and there is no need for treatment except pacifying or attending on the patient properly. So that was all those things were being conveyed over here. Now, history taking process, establishing rapport, listening and questioning, observation and interrogation. Obstacles to history taking. This is very important as far as clinicians we are concerned. Fear. No, we are not afraid of the patient, I believe mostly. The patient has a fear of the doctor, what he is going to tell, what he is going to suggest, etc. Antagonism, mental cloudiness in some patients. Incoherence, if you are talking in one language and he is talking in another language, even with regional variations. Language barriers, rambling and talkativeness. This is also a problem mostly for us. Sometimes you leave the patient, you make the patient feel that you have patience to listen to him and your half an hour is gone. So such instances are there. But still, I think history taking process, chief complaint, history of present illness, past, family, social and occupational history, systemic review like respiratory system, gastrointestinal system, genitourinary system, nervous system, whether there is a history of VD and of obstetric history, etc. Mental status, appearance of the patient, alert, cooperative, oriented, about his memory status, etc. Now, taking history and observation, this only I would like, I am not going to explain it out. There is, in the following slide, some pictures are there. There is a Russ sign, they call. See, I was talking in the few days back, 4 days back, in fact, last Tuesday. In fact, it is better for Ayurvedic people like us who are doing more of this, dealing with musculoskeletal complaints, dealing with them with Sneha Karmas to learn more kinesiology than true anatomy is what I believe. When we look at the results, how they are coming, it's better we explain it in terms of kinesiology rather than what material or structural change which are occurring in the tissues, because we are getting much results compared to the structural changes which can be evidenced. Many times the patient is okay, but the status of the structural change remains the same. So anyway, we had already told that we are treating the patient and taking into consideration the Vyadhi in the patient only. So one is Russ sign, one is Jarin sign, one is Hermit sign, and one is Barrelois sign. So some signs which can be elicited in this patient can be vital signs like height, weight, blood pressure, pulse rate, respiratory rate, temperature. Patient preparation. Why should the patient be gowned prior to evaluation? Many times you have to derobe the patient to see whether there is any muscular wasting or anything like that. So, it's a usual procedure in the Western countries, which we have not started adopting. Many times we have a wrong habit, which was also mentioned last time, that we don't examine the patient at all. Once we hear the complaint, we have a ready-made prescription for him. Maybe we are telling that, okay, he is a Stula, he is a Krisha, so I will give this medicine or that medicine. The choices actually the panel proposed that only, that there should be much attention going into the examination of the patient. Specification of the problem has to be there, so that specificity can be brought into the treatment protocol. Environment, explain procedures. That's one thing I would like you to attend to. You explain the procedure of examination. General inspection is a series of accurate and meaningful observation. Okay, you observe, okay, I did an inspection, but whether that inspection is accurate and meaningful, that should be seen. Now, inspection involves 5 special senses very close to our observation with our own indriyas, pratyaksha, pariksha, sight, hearing, touch, taste and smell. Inspection posture, body movements, gait, speech, surface scars and wounds. This is one thing which you have to bear in mind. I told about the posture, the body movements when the patient is presenting in front of you, the gait, the speech, whether there is a slurring of speech or anything like that, and any signs of injury which he is presenting with. Nutrition, stature, body temperature, breath orders, these are all the things which are considered. Now, palpation, static palpation and flat palpation, superficial and deep palpation of the cervical area. Motion palpation, while palpation is being done when the neck is moved. That is, technique evaluation includes motion palpation. This would be a this one is from the musculoskeletal system, which we see that you don't do static palpation, where you have to elicit if there is any change or anything which is occurring in an organ or in a site which can move. So, many a times you can see that once you are palpating, you can see light crepitus being elicited, palpable crepitus can be observed, etc. Superficial tissues, deep tissues and joint plays, the movement of the joint has to be palpated. Detect abnormal tissue textures. Already one example had been given about myofascial swellings, which can be dealt very clearly very easily or very successfully by Ayurvedic therapies. Evaluate symmetry. You have to evaluate whether even you can see that sometimes with severe pain, the patient presents with the arm put very much down, and you can compare the symmetry on inspection as well as you can observe if there is any wasting which is leading to that dissymmetry. Detect and assess movements, detect and evaluate changes in the findings. Percussion stroking with the reflex instrument, spinous process, interspinous ligaments and paravertebral muscles. All, it's a very, very, very detailed examination. You can see that. Then this I also don't know, I came across when I was looking at it. There is a thing called dynamometer, elbow flexion to 90 degrees. With that, this one is being made. I'm sorry, I cannot explain it because I also don't know about it. Inclinometer, this is interesting because how much inclination, we know that the cervical spine has a lordosis, normal lordosis. Here, inclinometer is an instrument. The most accurate mensuration or measurement of spinal or joint motion is possible to be done with this instrumentation. I was just gathering all these things only to see that if we are going in for a research project like that, sometimes all these things will come in making something which is objective more subjective. Impairment ratings and independent medical examination. See, this one is a common thing, instrumentation, goniometer. Easiest to utilize for most joint range of motion examination. Goniometer is easily available and it is used. Reflex hammer, Babinski, which has been already told, this clinical situation which you can very much detect with those things have been told. Buck reflex hammer, Taylor reflex hammer. So, understand that we always call these 3 types are available with us or will be available usually, we don't know the name, so just I put that. In this one, positioning of the patient, relaxed nature of the patient, etc., has to be seen. Deep tender reflex testing, identify the grade of reflex being tested. Then there are using of tuning forks also for this one, utilized with orthopedic examination. Exact this one can be discussed later. Test for osseous fracture pain and perception of vibration, usually that is the thing. Safety pin is a good instrument which you can have with you in clinical examination. Sterile, large enough. Test for sharp and dull pain sensation. So even a safety pin can give a lot of information, maybe which you can expect to find in MRI. Cotton balls, test of light touch, superficial touches. Paper clips, test for 2-point discrimination but not for pain. So there are two faculties for pain sensation to be seen. Cervical range of motion testing, the picture itself is very clearly, so stretching and strengthening exercise of neck, you can see that all these movements of flexion, extension, rotation, sideways rotation, lateral flexion, all these movements have to be tested. Range of motion evaluation, here these things you can note that symmetrical motion, free of restriction, pain free or proactive, passive, active and restricted isometric movements, all these things have to be observed and recorded. Orthopedic manuals, anatomical structure tests, see these are different tests which has to be seen. Dural tension, you can see that there are this limited sign and all are this one. Once you flex, if the pain is radiating to the back, neck and the back together paining, or from the neck it is radiating to the back, such conditions are there. Foraminal canal patency, that is when turning the pain will increase when there is more of compression. Spinal canal patency, ligamentous, muscle, tendon examinations. Now assessment protocol we have already told. This is the Russ sign. There is a procedure of grab, there is a procedure, head upon removal of cervical collar, may use hand to lift the head when rising from supine position. It has to be tested. See, when suspect upper cervical spine instability, that is C2, C3, very risky thing. Immediately, this is one thing which I wanted to tell, that once you remove the support, patient will immediately hold the head like that. So that is Russ sign. Shoulder abduction test, nerve root irritation, shoulder abduction test which is usually done. Then Valsalva manner for IVD syndrome, intervertebral syndrome or tumor space occupying lesion. Then cervical distraction test for nerve root facet or myospasm. So there are, just I wanted to tell you that there are enough and more methods or tests which can be done by us in a clinic when we are going deep into the study of the problem, rather than spending a lot of money on the other investigatory things. So this always suggests, these always give an indication of what function loss will be there due to this particular any ailments of the cervical spine. There is another thing called Soto-Hall test, another swallowing test. Difficulty swallowing might be related to a space occupying lesion anterior to the cervical spine. It's a simple thing which patient may be complaining, I am having a neck pain, but if whether dysphagia is associated with it, if it is, then that has to be ruled out. So swallowing test, which I think we never imagine that there is a possibility like that. Cervical compression test, many methods are there. Of course, I told that this presentation is for more than an hour. I am just making you see the slides, that's all. Common cervical provocative test, cervical provocation, test for dural sheath, nerve root or spinal nerve involvement, pressing on the head, etc. Cervical orthopedic test, don't memorize the test, practice them with comprehension. Many a times when we are asking the assistant or student to check the SLR, and whether there is what is the finding to be made through SLR, whether it is in relation to the any compressive this one of the nerve which is coming out, or whether it is any joint problem only which is limiting the motion, That has to be very clear. So with comprehension, discuss the test and practice, relate practice and discuss the relevance of the test and so on. Now these are what you call then the associated things: nerve injuries, neuropraxia, axonotmesis and neurotomesis, usually occurring with cervical myelopathy and compression syndromes, etc. So I think pathological neurological responses are dysesthesia, paresthesia, brachial plexopathy or neuropraxia has been told. That is one example for neuropraxia. Atrophy or denervation, demyelination conditions, motor reflex changes also. So I think we will not go into the explanation of all those things. Most severe pathological neurological responses in cervical spine, please remember, hemiparesis or neurotomesis. Neurotomesis, hemiparesis can also occur. That's what I told, one failed case which I had. I thought it was a central, just a CNS lesion or Pachagada like thing only, and then transient quadriparesis. Sometimes very difficult. Patient comes and tells that sometimes I get numbness all the four limbs and below the neck. Sometimes I am okay. We had learned about transient ischemic attacks as far as this one. So there are things like transient quadriparesis also, which is due to lesions of the cervix. Okay, I am not going into neuropraxia, etc. Myelopathy already has been described. So I think that I will wind up. So that was just to very briefly tell how we can go about with cervical spine examination in a patient who is complaining of some symptoms or signs which we feel that it is from the cervical region. This is just a fill-up thing, and I excuse for my ignorance of many of the things and also the little time spent on it, but that will complete the series of this thing leading to the presentation, I thought. So that's why. So now we will go into my presentation proper. So that is, I would rather put it as Ayurvedic interventions in the management of cervical spondylosis, various strategies only. So it's not a definite, we still know that, and already it has been talked about, when we all sit together who have learnt Ayurveda itself, and then while we try to make a prescription, there can be differences. But all those differences can be within the limit or sometimes off the track also. But once it is within the limit, then we know that we have some common strategy. So that's only I also want to, we have common strategies when we are planning for treatments in such conditions, and let us look at through the different strategies which can be adapted while we are treating the patient with cervical spondylosis, already diagnosed maybe, and then I will again, just to review, give a chance of Ayurvedic perspective to diagnose cervical spondylosis and plan strategy of treatment. So I have reached that point only. Planning will be based on the diagnosis, specific diagnosis, proper diagnosis. To understand the clinical presentation, my presentation has to understand the clinical presentation, pathology behind them, treatment modalities available, classification of patients, selection of treatment procedure, application and evaluation. So clinical presentation as we get in a cervical patient is mostly Griva, Prishta, Graha. Sometimes it is Griva Graha only, or Griva to Prishta Graha, and Griva, Prishta, Ruja. I am not using the very particular, okay, this is from Vangasena or this is from Yogaratnagara or this is from Charaga. I am not telling that. Whichever commonly used Ayurvedic terminology which are coming, we have adapted to, I have adapted into this. There is one symptom called Khalli, which is told along with Grudrasi. Khalli is the one which is correspondingly told in the upper limb. So, which has Khalli Tivra Ruja. So, very clearly the symptom is of patient is coming with very severe pain. Even his looking this side or that side is causing so much of pain. Bahushula, Urashula. So Bahushula is there or Bahuruja is there, complaining of upper arm pain, which may be whole arm pain also. Then Urashula, many a times this is one thing which, if it is happening on the left side, radiating to the pectoralis, it is one thing which takes the patient to the cardiologist, or sometimes even we will be so doubtful that we will have to ask him to take a electrocardiograph to rule out that there is no cardiac involvement, because it will be similar pain. Maybe the patient is on some painkiller also, which has induced his hyperacidity syndrome. So there will be epigastric pain. There will be pain radiating from the neck to the left chest up to the nipple. So naturally there will be all the confusion, which is generally there with all the practitioners. Nobody can rule out very simply that, okay, this is the thing. If he is your own patient, sometimes whom you know, you are a family physician to that patient, you may be able to. But otherwise, if he is brought into with that complaint, it is very difficult. So we will have to rule out that. This occurs in many conditions which had been already discussed in the morning, that combination of two or pre-existence of a disease with the presenting condition. Diabetes with, one example was asked, diabetes with carpal tunnel syndrome, like cervical spondylosis with carpal tunnel syndrome. Like. So Urashula, if it is happening on the right side, we are much more happy, because usually it is not, all persons are levo-hearted, not this, dextro-hearted. Patient, we are able to, if we are documenting, in this hospital we know that we are documenting also, so these terminologies are the presenting complaints usually. Ababahuga Vishwaji, which has been already told, Ababahuga, there are various considerations was whether Ababahuga can be this or that. I am bringing in because inability to lift the hand to up to more than a certain extent, that is the thing. Vishwaji, very radiating pain from the, either from, mostly from this side to the, from the extreme to the, shoulder or neck, or from the shoulder to the hands. Bahu Hasta, Manya Ruja. We have only when we refer to Manya Stamba, etc. conditions which has been told in Vadavikara. Manya Ruja, Manya Stamba. Manya, when you go to Marma, then Manya is dealing with something. Neela and Manya are Marmas, Siramarmas, which have a lesion. If they are affected, they have a lesion of either causing loss of speech or difficulty to talk or speak, or difficulty for understanding the taste. So it's a particularly, it's a very this thing. So that Manya is not this Manya region, we can tell that Manya Ruja or Manya Stamba. Bahu Hasta Supti. Then Supti is one of the lesions, one of the things. So we can see that all these things are Vikrita karmas of Vata in that particular avayava. So Samsa Vyasadi Vikaras, almost those symptoms will be told. People will be complaining of very different things, different presentations. Somebody will be telling that Kadachalanda, somebody will be telling that Vedananda, somebody Porichil, somebody will be telling that Tela Gottiya Vola Vedana. So different presentations of pain can be there. Bahu Hasta Daha also can be. Paresthesia can be either numbness or burning sensation. Then Kunitva, deformity also can be resulting in some conditions. Maybe it's a temporary deformity due to the pain. We told about the listing. Patient is comfortable because he, if he keeps the neck like this, the pain is not there. Or if he keeps the hand like this, pain is not there. Many times with severe pain, patient comes like that on. So it is actually the nature itself is immobilizing the area, trying to immobilize the area, and that is why he gets that posture or stature. So deformity here is not established deformity, please understand that it is the postural presentation. Vyadhi Moolasthana and doshas involved, the morning session itself has explained that we are concentrating on the Prishtavamsha. Many times in Vata Vyadhi, if you refer, there is, I think there is no reference of the word Prishtavamsha itself. In Vata Vyadhi Nidana, if it is seen through, it will not be there. But in Marma, if you go through, there are at least 10 times mention about Prishtavamsha, Ubhayadaha, many situations where the location of the marma is told. Prishta marmas are told that it is related to the Prishta Vamsha on both sides, etc. And when you go to Bhagna Chikitsa also, you can say that when the asadhyatva or kritrasadhyatva of the Bhagnas are told, tell that Prishta, wherever a fracture occurs in the Prishta or Prishta Vamsha, it is, when Kavada Shayanam is told, it will be told. When the Sadhya Sadhita is described, it is told. So, we have to understand that there are references in our book. If it is not told in Vada Vyadhi, it is our mistake that we are looking just there, not elsewhere, where it has been told. The doshas involved, Hasti and Kasheru, I have included. Taruna Hasti, Sandhi, Achala Chala. This has been described by the previous speakers. Sometimes as thoracic spine, why it does not occur. Spondylosis does not occur mostly in, that is described. Chala Achala. Mamsa Reshis, Kandaras, Snayus, Griva, Prishtapadesha and Skanda. Here Skanda also I mentioned that because very basically you can see that the patient does not complain of pain in the neck, he does not complain of pain in the arms or shoulder, he complains of pain in this place. It always points of where you have the pain, he just puts it over the Amsa Marma. Griva and what you call Amsa or Madhye. Or he puts this thing to the Amsa Phalaga. It's paining here. And if you examine also, you can see that those will be the most tender points, what they call as the myofascial trigger points, etc. So, that is why Skanda has been also told. And I just differ from or try to explain it out. Dr. Srikumar told that Nasya. We get the suggestion regarding why it can be used from the Dinacharya itself. What is the use of general Anutaila Nasya as a Dinacharya procedure? You will get good Skanda. So, as a region involved in the along with the cervical region, it has to be considered. Then Dushti involves already, as explained, this Mamsavahasrotas as such, Medovahasrotas, Astivahasrotas and Majavahasrotas. It had been explained over in the morning. Now, this one is quite important as far as when we are planning the strategy of treatment. Basic functional understanding of the backbone or the cervical region, total backbone as it is or Prishta as it is has to be understood. Mostly we have to take into consideration two doshas, Vada and Kapha. And since when we are considering this Griva Kasheru and the Prishta Kasheru as well as the Kati Kasheru, Sthana wise there is importance of Kapha here. And that's why many of the scholars, when we discuss the strategies, Sushruta has mentioned about Vamana even in this one. In a Vamana in a Vata Vyadhi, because of the Sthanika, this one, which has to be done by a Kushala, or it has to be done with much Kaushalya, it has been told. Otherwise, we are going to damage more than what we are going to repair. So, flexibility and stability are the opposite attributes which coexist in the backbone. This explains some of the things which were, I feel that may not have been that much comprehensible. This one, whether to use, when you use Snigdhada, when to use the other thing. Many of the points which were discussed, I think, it is attributing this structure as a whole has to be attributed flexibility as well as stability. So, how we are going to come about that, that is also explained. It is stabilizing the structures which are supporting the bony tissue or the kasherus when they are getting weak. In fact, the chicken and the egg story is always there, whether the supporting structure gets weak first and then the other one, or the main structures first and then the supporting structure, or whether they go on happening together. I believe that they go on happening together, because you have the sequence of Mamsa, Majja, Mamsa, Asti, Mamsa, Meda, Majja and Asti. So, whenever there is one lesion occurring at the Mamsa level, if it has to occur at the Mamsa level, that's why we come that everything starts with the food only. Because it has to get affected by the changes which is occurring in the Rakta Dhatu, which should have occurred in the Rasa Dhatu and ultimately in the Agni. So, whether it is non-absorption or malabsorption or over-absorption or under-absorption, whatever it is. This is responsible for the normal function and also for the abnormal presentations. See that the complaints related to cervical spine usually will be either related to flexibility or stability arising out of that. Restoration of this is aimed in the planning and execution of treatment of a cervical spondylosis case. Reference has to be taken from Gridrasi. Now, why this Kabha is also involved? That we will have to take the reference from the presentation of Gridrasi only. There is Kevala Vadaja as well as Kava Vadaja Gridrasi being mentioned, which we will have to attribute to with the this one in the upper arm. Nidana of Vatavyadi, Nidana of Bhagna and Sadhyavrana. That is Abhigada. Abhigada, as we told, may be a single Abhigada like a whiplash injury. Again, when we are talking about cervical spondylosis, whiplash injury is a differential diagnosis. So, all the traumatic conditions need not be, but once we are treating as a patient who is coming with pain in the neck and the arms with other symptoms, I have included that also. Bahya and Abhyantara, that is again another classification which we can give, whether it is if it is Abhigadaja, it is Bahya, and if it is Nija, it is Abhyantara, Nija and Agantu. Congenital anomalies already had been talked about, trauma, degeneration, inflammation, sometimes endocrinal factors, psychological factors, very much, I think that has to be put in the first. Marma involvement, again, if Dr. Sreekum or Suresh Kumar sir was there, then I think he would have dealt much with these things. Because in his absence, I can just put this slide. Lakshanas of Asti Marma, Sandhi Marma and Snayu Marma Vyatha Lakshanas will be available in cervical spondylosis patient. Vaikalyagra Swabhava indicating predominance of Vayu and Soma. See, these marmas are generally, and the marmas which are there are generally Vaikalyagra. They are Vaikalyagra because that physiology has been explained. They are Vayu and Soma predominant. That Soma predominance makes it Vaikalya. There is no much of what you call fatality which is involved in that. Trikadika has to be considered, Kakshadhara has to be considered, Amsa has to be considered, Amsa Falaha has to be considered when we are talking from our Marma Shastra. Other Prishta related marmas surely has to be, because there will be a reflection of this thing on that. In Tamil there are many marmas which is to be considered. In Kalari Chikitsa there are other marmas which are considered. I am just giving an example of male Shuryadi, Natal, Kaikuti, etc. Vyadi Marga, Madhyamaroga Marga has been already told, such as the Kritrasadhita, Yapyatya, chances for recurrence, requirement of prolonged treatment, resultant disability, that is the Vaikalya Karatvam. Even if you treat, sometimes the patient's posture is not changed. Even if you treat, he is not able to endure as much what he used to previously. Loss of strength which has occurred in the muscles may not be regained fully. So, resultant disability, rehabilitation. For example, sometimes when we are treating, we can just stall the process only. Patient will come to us complaining that I was usually able to lift any small things as well as big things. I could hold it properly. Now I am not able to. So that whether we can limit this disability to that extent only, that is also a target of our treatment. Samprati, Kevalavada in Mamsa, Asti, Tarunasti, Sandhi, Snayu, Kandara. So now Vata Gatatvam in all these dhatus has to be seen. The symptoms which arise due to that will give a symptomatology for any of these lesions which are occurring here, and that is what we see in the patients. Mamsagata Vata Lakshanas will be there, and that is the simplest thing when it may not have gone in for totally established osteophyte formation and other things. It may be a simple Mamsagata Lakshana, which usually if we treat in the normal way with a root of Sweda or anything, it may relieve also. Sometimes we talk about in the low back, lumbar, which will be relieved very fast, like that in the neck. As examples were given in the morning, you have a night travel in the bus and then you suffer a pain. It will be relieved by simple application of heat. So it can be Mamsa Gata only, it can be Mamsa Asti Gata, it can be Mamsa Tarunasti Gata, then it can be Sandhi Gata involving the Sandhi, which leads to an explanation why cervical spondylosis can be just treated as Sandhigata Vata. Then Snayu and Kandara has to be taken into consideration because of the Lakshanas, Snayu Gata Vata Chikitsa and Kandara Gata Vata Chikitsa. Snayu Gata Vata Chikitsa Lakshanas have been told only. I was rather talking on that many times the discussion of Snayu, what is Snayu and Kandara also came in. Kandara, when we see that, when you see through Vagbada Nidhana, you see that Snayu Gata Lakshanas have been told, Vata Lakshana has been told, and example is given as Gridrasi. But when you go to Gridrasi, the explanation is that when the Vata is affecting the Kandara, ya Kandaraha. So then if you go back to Anga Vibhaga and refer, then we see that okay, Kandara is one type of Snayu. So Acharya has never gone wrong. If we go with the Bhasha Institute language, that's what I tell, Kandara is equal to tendon, Snayu is equal to nerve or ligament, then we will be wrong. But all these Lakshanas has to be considered when we are considering a case of clinical presentation of what you call cervical spondylosis. Kabhavada Samsarga in all these things, Kevalavata as well as Kabhavada Samsarga. So we can very clearly tell that in Lakshanas, when Kava is involved, Stiratvam will be there, stiffness will be more predominant than the pain. And Vata is Gurutvam will be more predominant over there. Here the patient will be complaining of heaviness of the arm or the neck or the shoulder or the back. But in the other one, if it is Kevalavada, mostly we can see that there is severity of the pain which is more rather than, so and the patient will be Sarvasu Avastasu na Sharmalabade, like in what you call Bhagna. Because of the pain, he will not be comfortable in any position. He tries to hold like this, he tries to lie down like this, etc., without pillow as told, with pillow, nowhere it is getting, he is getting comfort. So that's why it was suggested also that sometimes the comfort is there when he reclines with a soft pillow in the shoulder, on the affected shoulder or the painful area, and then on the neck. So it is not a dictum that the pillow should be avoided like. So, but we have to understand from this that there can be, and this will lead to the change in the prescription which we make, whether it is Sahacharadi which we are going to give, or Ashtavargam which we are going to give, or Maharasnadi which we are going to give. Astidhaduchaya and Madhyadaduchaya. Astidhaduchaya, when there is no neurological symptoms, we can see that mostly Astidhaduchaya we can get satisfied with, but in demyelinating, when there is cervical myelopathy, we can surely see that there is an involvement of the Majjadadu, and so we have to consider that Majjadadu Chaya also has to be there. There will be Nidra Nasha. Surely there will be, because of the severity of the pain which increases during night, there will be no sleep for the patient. He will be so disturbed during night. Samprapti, then there will be the Sama Avastha also and the Avarana Avastha. Sama Avastha or Nirama Avastha, and then the Avarana Avastha also. Both has been described in the morning presentation. Pathological events, mostly it has been told that even though there can be so much of radiological evidences regarding if the cervical spondylosis, there may be no 70% or so it has been, I read in one of the literature. There may be radiological evidences but no complaints for the patient. And in few of the patients there will be pain, stiffness, etc., but it will there will be never any radiological this one. So as far as this orthopedic radiology is concerned, the dictum is that please correlate with the clinical condition. You will see that in any report there will be that thing which has been, please correlate with the clinical condition. This thing will not be relevant for that this one. But once it is there, then we can see that okay, now we can warn the patient that if we are already seeing some osteophytes, reduction in space of this thing, etc., then we can tell that, oh, you are playing very active football or we are playing very active shuttle badminton, please slow down, just don't smash, just volley. That's what we can tell. So those things will be helpful in that. In those conditions, mostly the cervical lesions, intervertebral disc prolapse stands out much, with much chances. So that's what I have told this. There are stages already described, I think, protrusion, extrusion, intermittent prolapse, that's a condition. Patient is happy for some time, but sometimes he is unhappy because there is a movement of the discus pulposus, and there is not a break in the annulus but just a vent which gives that. I would always tell that I don't know if I am wrong, but I usually complain with the sweet thing, the disc and the material inside with an eclairs toffee. It has a soft inside and a hard outside. And if you put it on the table and just apply pressure on it, you can see that it will break and the soft material coming out. So this is the simplest example I can give you regarding this. And as far as treatment is concerned, as far as quackery treatment is concerned, quackery, kalari, marma chikitsa is concerned, I will tell that many times the claim that by manipulation I am pushing the disc back into its position and sealing it is the most, what you call, atrocious or wrong message you can give. What we may be trying is to resolve it, that's the thing. Scar tissue extra, stages of inflammation, always there was in the previous presentation also it was there, whether it is simply a degenerative condition or a inflammatory stage is there associated with it. We have to tell that any disease starts with jara and ends up with vatarakta, and so there is an inflammatory phase. In this, the phase may be very less noticeable or it may not be noticeable because it is lying deep into this one. Condition called Rakta Paga, we would have learned all the Lakshana. Paga is occurring in this one compared to the cold abscess. We call it abscess, but there is no signs of abscess. There is no classical symptoms of inflammation in cold abscess which can be observed outside. But we know that in like in TB, psoriasis abscess and all, cold abscess, there is lot of already pathology going on inside which is not noticed outside. Like that, the inflammatory changes in the disc material or the bones or the surrounding tissue, it's going on, and which may not be noticeable or it will be neglected. There may be simple pain which may be neglected. Later it establishes. Dislocation or derangement, that is one thing we have already told, and then degeneration. So whenever there is weakness of the supporting structure, there is dislocation or derangement. Here, when we are talking about the majja, mamsa majja and this one, please also take into account the upadadus of it. Upadadus of it, when they are taken into account only, we can see that snayus, kandaras also can be explained within that what you call circle. Differential diagnosis already told, so I am skipping it. Congenital abnormalities, cervical spinal canal stenosis, which may be a what you call congenital one itself or developmental one. There can be developmental also. See, there are, as far as spine is concerned, we are very grey. That's why it was told also. Whether it can be told as a disease itself is a question. Because many a time it is very difficult to describe this kyphosis or lordosis or scoliosis, whether they are developmental, they are considered developmental deformities. The bijam will be there within that itself, we know that. When we explain kubjada and all, it is told as jadaja vikarasis, sahaja vikarasis. So we know that, so it's very difficult whether the stenosis is to tell that it was already there or is going on establishing. Spondylosis, osteoporosis, tumors, arthritis, other types of facetal arthritis, etc. Factors determine choice of treatment. Now this is the area where we are getting into the subject, like built, whether they are heavy or light built, which will determine right from putting the traction or any treatment we are doing, whether we are going to treat a heavy built patient or a light built, or Stula or Krusha. Strength. So Dashavira Pariksha, Sara Pariksha, Samhanada Pariksha, whether he is a Mamsa Sara Purusha, Asti Sara Purusha, they don't get these diseases. The other people have the tendency of getting these diseases. Strength Bala, Alpa, Madhyama, Uttama. So alone or associated with other diseases also is a matter which determines the choice of treatment. Occupational or not. We had already had a session on occupational hazards, occupational treatment, occupational chances, like if you are using a vibratory instrument for a long time, if you are using if you have to compromise for a position of the neck like this, for a very long time, etc., etc. Those are the things. Srikumar sir mentioned that it is not the one designed for bearing weight or not to that extent or bearing vibration, etc. Location and Vektasthana. So, location treatment modality will differ depending on the location and the Vektasthana also. Selection of treatment depends on accurate diagnosis. Here also cervical spondylosis with the area of cervical spondylosis only, with special reference to the level of IVDP you can think of. The grade of root compression, duration of symptoms, personality of patient, demand, requirement. This thing also we have explained out. See, this is many a time what we discuss of. When we are discussing very, very scientifically true science, then all this patient, demand, requirement is pocket. Nothing comes into this one. But as practitioners, when we are doing practical approach to the patient, his dukkha is multiplied by many things, not just this dukkha. So, when we are designing the protocol, scientific protocol treatment, I will tell you, but this varies, that's why I have put it over here. Duration of symptom is one of the things which gives us whether it is of acute or chronic, this one. Grade of root compression, here comes the importance of the modern investigations also. So, we need not be, sometimes, that's one mention I give, surface it will be a tip of the iceberg. Surface the symptoms are very, very mildly exhibited, but basically there will be some problem over there. Especially we don't think of spondylolisthesis in much occurrence in cervical spine, but as far as back is concerned, if spondylolisthesis is there, as far as Aushadha Chikitsa, I don't know that whether that has a big factor, but we are not stopping with just Aushadha Chikitsa, we are all manipulating, we are putting the patient for at least Abhyanga procedure. I don't tell of Kalari massage procedure or Padagara Chikitsa, etc. But at least we are putting the patient to different positions. Sometimes he is not able to 7 classical positions if we are trying to do to this patient. Sometimes he is not comfortable on one side, but still once we don't realize that, it will be damaging. That is why grade of root compression, etc. has to be understood, and that is where in design of treatment or selection or rejection of a treatment, this modern investigatory procedures give us a guidance. Personality of the patient is very important. Sometimes you will have to use only Sattva Avajaya Chikitsa. Counseling will be only required. Sometimes only, as Sir told, that if it is you through the history taking, you observe that the lady employee is in a hurry, she takes bath in the morning, does not towel her this thing properly, she goes to the ICICI bank, sits under the vent of the AC. For her, what we require, if we study the history, it will be only Rasnadi Churna on the head, with an advice that you towel your head properly or at least get a hair dry. Even if your hair goes, your neck will not get damaged. So, that is the thing. So, personality of the patient, or sometimes see these symptoms are more in patients who are alone. A widow whose son is not away from the scene, she is alone there, or a widower who is alone. All these symptoms will be increased. So, where we will not be able to substitute for something, but we will be able to at least counsel and tell that, okay, half of the pain is due to your Manasika Dukkha. So, that this part I will treat, that part you also handle properly. So, Sattva Chikitsa will be. So, that is why personality of the treatment. Demand I will be agreeing or disagreeing, that we will talk about, because nowadays patients are there that, sir, I have this complaint, so you put me in the IP and treat. That question came.